Your Excellency, let's talk about your organization, Wellbeing Africa.
Well, the Wellbeing Foundation Africa, I started formally in 2004 because I realized that there were a lot of solutions around the world that I could find and practices that would help us reduce maternal mortality in Nigeria. At the time that I started the foundation, we had about 1 in every 6 women dying in childbirth or in the week after childbirth. And we also knew that if a mother dies giving birth, the child's chances of survival are much, much, much less. And I really couldn't understand it. I had gone through a very near-death experience myself, having my first daughter. She was actually a twin, and I went into labor at 28 weeks and lost one. Really had to fight for her life. And so here I was knowing about all the global innovation, but I was in a hospital in my country, which was one of the best hospitals, but it still wasn't good enough. And they just couldn't get the right help to me at the time that I needed it. At the same time, I knew that the doctors, the nurses, the midwives, they were really trying their best. And when I sort of recovered from the grief, I don't know if you really recover, but when I started to gain myself back, I kept thinking, but it didn't have to be like this. You know, I could have had the operation as soon as I needed it and not had to have that 1 hour wait for an anesthetist. I could have had enough injections of surfactant to make both the baby's lungs, mature quickly. And I was lying there, in the bed and just thinking, if this could happen to me with everything that I have and everything that I know, so what happens to the people that don't have that health literacy, that don't have the resources? And I became more interested. Initially, actually, I set up a foundation with 5 friends of mine to help children with heart disease, and we were taking them to Israel for operations. But when my husband became a governor in 2003, I became very close to the front line that possibly I would only have been reading about. And I saw that a lot more women were dying than we had explanations for. So I went to see the health minister. I mean, the one good thing about being a spouse in the public eye is that when you call someone, they receive you. And I went to visit the health minister, then Professor Lambo, and I said, look, I'm keeping a tally chart of just our state, then Kwara State, and I don't understand it. Out of every 10 women, about 4 of them actually are dead by the time we name the baby. We have a tradition, we name a baby on the 7th day after the baby's born. So it's a very timely reminder of who made it and who didn't make it. And I've since discovered that the biggest cause of death in Nigerian childbirth is actually postpartum hemorrhage. But the second biggest cause, so postpartum hemorrhage accounts for about 35% of deaths in childbirth. And the second biggest cause is maternal sepsis. So that means even if you get past the first day, with your life intact, you're running the risk because of our very poor wash conditions of having sepsis. And I've been working in different ways ever since. First, I started with data. I wrote a health record for Nigeria because I saw that the countries that have very good survival, the mothers hold their health records themselves and they become partners in having a better outcome. So I wrote a health record for Nigeria. And now I do things like have a program called EMONC, where we're training health workers using anatomical models. So I guess you would call it a safe surgery or a quality improvement program, but it's making a big difference. In the state where I'm running EMONC, we've trained 62,800 health workers, and the mortality rate immediately dropped by 18%.
It's interesting because I know you've said that progress in Nigeria really is progress at Africa at large.
It is.
Explain that comment.
Nigeria is probably the most populous country in Africa, and we have the highest rate of what I would call fecundity. We seem to be very fertile. We have a lot of children. We've got quite low contraceptive usage. So we do have 8.2 million or more pregnant women in our country every year. Now, if Nigeria makes it, Africa will make it, and the rest of the world will make it. But we also seem to be the second biggest contributor to most of the world's problems where it comes to women, children, and adolescents' health. And yet, we're a country that loves education. We have so many contrasts in the country. Nigerians love education. We like to send our children to school, yet we have 11.1 million children out of school. So you have to really see that poverty, and not just financial poverty, poverty of access is really at the root cause of all our problems. I really, really believe that the best way to empower a woman or a girl is to educate her. And I don't believe education is only in school. Education is lifelong. To make sure that all this innovation that we come here and see in New York and talk about actually goes straight to the front line. And that's why in 2015, as we were leaving the MDG era and entering the SDG era, I kept thinking about it. I said, wait, I come to UNGA every year and I'm thinking, okay, we're here in UNGA and we're saying MDG and we're saying SDG. But if I stopped a woman in a village in Nigeria, would she even know what I meant by SDG or MDG? And I was trying to think, how can I get this knowledge that I come and I pick up every year and I refresh every year? How can I get it to a woman at the point where she needs it the most? And for me, the time when she needs it the most is when she's pregnant. It's also when she's ready to absorb information. So what I did is I started up a program called the Mama Care Program. I actually started with 2 midwives. In 2014, I had become the Global Goodwill Ambassador for the International Confederation of Midwives. And I started seeing the work of midwives around the world, their professionalism, and the way women trust them. A woman can have a conversation with a midwife in a safe space. And I know it sounded like craziness at the time, and I actually went against my team's advice. So I employed 2 midwives, and I said, look, I have these big ideas to reach every pregnant woman with the information she needs about her pregnancy, so she knows what to expect and so she knows when something is abnormal. Can you help me? And they said, yes, of course. We can go to hospitals and we can give antenatal classes. So I put those 2 midwives to work. I employed them directly in the foundation. And they very quickly came back to me with some very surprising impact results, I would say. They would be going to a hospital where maybe on a normal antenatal day, which is once a week, they would be maybe 20 or 30 mums. And all of a sudden, the mama care midwife would start going to this hospital every week. And within a month, there would be 90 mums at the class. And the actual hospital midwives loved them because they're bringing in customers. So it was a very impactful program. And today, 4 years later, I have 74 midwives working directly with the foundation. They are working in 655 health centers, primary health centers, simple health centers around Nigeria, and they're seeing 11,000 women every month. We haven't lost one mother to death.
That's fantastic. It sounds, too, like what you were initially up against in part was internal cultural perceptions just within Nigeria's community, male, female, maybe gender-based. But having been to Africa numerous times, one of the things I find, too, is we ourselves coming from the West almost have been, may I say, sold a certain bill of goods that falters our perceptions. So how do we work, especially when you're at the UN, when you're here at New York, how do you work to change our perceptions to get it past mere poverty porn, which is an expression I had heard there, and get us focused on the needs, the resources that would make a difference?
The one thing to really understand about Africa, and I think about Nigeria in particular, is a lot of the absolute basics are what have been neglected, while the more blue sky stuff, people are doing. So, we have Bitcoin, but we don't have water and soap in a hospital. And I think we need to approach, I don't want to call it our challenges, I would just say the situation on the ground. We need to approach the situation on the ground from a position of honesty, from a position of transparency, and from a position of accountability. And if we're honest about our needs and come to the table not from a donor-beneficiary narrative, because if you are a global organization here, it doesn't matter what solution you have, you need us. Because we are the market, and we are a very huge market. And we also need to be able to have the education and the knowledge, and again, the honesty and transparency to pick the solutions that work for us. I am in constant touch with my midwives, and they are in constant physical contact with the moms. So I get what I consider to be very accurate data.
Well,
Very, very accurate.
Well, even the nature of your midwives, really, it seems to really be not only empowering them, but I would say even it's changing perhaps the role of women and the perceptions of women. Is that
I
changing?
think so because midwifery was traditionally a female profession, and we're actually coming up now to the year of the nurse and midwife, and I'm expecting to see women, really women in global health, take their position not as an assistant position or as a second tier, secondary position, but actually as leaders. You see them in villages, in towns, here in New York. A woman giving birth is the same wherever you find her in the world. And this is a traditionally female profession that has really shown that we can save lives, we can be invested in. That investment becomes a dual or triple investment to invest in others. And we can actually give what you call population health. If a health facility and the medical professional inside that health facility is good enough to deliver a newborn safely, it's good enough to give health to the family.
Indeed. Well, you're doing all your work that you're doing, and you're representing your country and your organization so well. A charge to us. What do you need from us if you would put the three things to the table? This is the resource we need.
Well, first of all, I would have to say we need primary health. The primary health front line is the front line where lives are won and lost. It can be very attractive to only invest in secondary and tertiary health, but I would like to bring health to the doorsteps of my people, and quality health at that. So I would ask for an investment in primary health. Then I would say that we cannot have health if we do not have water and sanitation, hygiene. I would like us to retrace our steps and go and fix that. It's not going to be an easy fix, but it's a necessary fix. And then for the third, if I really, really wanted something, the third big win is I would want affordable health to be available to everyone. I would like to hope that if any of us encountered a health emergency or even just managing a chronic condition, I wouldn't want the lack of money in your pocket that day to stop you from accessing health. I think that we need to build our systems so that we have enough money to look after our people.
Well, thank you, Your Excellency, for joining us at the FPA booth here at Concordia. I look forward to seeing the work on the ground there in Nigeria with you.
Thank you very much.
Thank you.